What affects your heart can also take a toll on your head. And now there's a new set of guidelines for Canadian doctors encouraging them to think about both the brain and heart health together. Marianne's been looking at these guidelines. What exactly are they trying to change here?
Well, they want to change the way both heart health and brain health are treated. They want a more holistic approach. So these are 11 new guidelines taking a look and acknowledging the link of both brain and heart health when it comes to treatment specifically, because we know past studies have acknowledged that overlapping risk factor for both health and brain, heart and brain health. But this is different because it's taking the cardiology and the neurology, putting them together so that it is a much more well-rounded, holistic approach. That's really the key word there. And we heard from someone named Patrice Lindsay, who spoke to CBC News. She is a researcher, also a health practitioner, and also someone who has a heart condition. And she talks about the importance of really marrying all of these aspects together when it comes to treatment for patients.
Sometimes the health professionals will focus on the heart or the brain, but not necessarily both together. So the way care is delivered in Canada, and especially, bigger cities, it's very siloed. And so a big part of these recommendations is to help increase integration of care so that when you go to a specialist, you're seeing the heart and the stroke, they're asking questions about other parts of your body and trying to put a bigger picture together rather than just focusing on one part and missing all the important nuances that go with it.
A holistic approach, I hear that. In terms of practical guidelines here, what's being suggested?
Because it's not uncommon for someone to know someone or also experience some kind of heart condition or brain condition. Is very common, not only here in Canada, but all around the world. So if someone has a heart condition, according to these new guidelines, it would be recommended for them to also be tested for their brain health, looking for things like depression and even dementia. And you see some other examples there on your screen. Testing for cognitive decline in people who have atrial fibrillation or an irregular heart rhythm. Also testing, screening for depression in people with coronary artery disease, or also treating the depression in anyone who has heart disease, and then also looking for cognitive decline and treating that cognitive decline if someone has an elevated blood pressure. So you see that connection there, which is really key. We know that they're also looking at not just a blanket approach to things, they're looking at gender, they're also looking at sex, they're looking at patient perspectives to really form these guidelines, and they're saying that's what makes this so unique for Canadians. All
right, Marianne, as we talk about heart and brain health, let's bring in a cardiologist. We're lucky we were able to page one in. Dr. Chris Labos, good morning to you.
Good morning, David.
Okay, let's talk about this. You're a cardiologist, so what does this change for people who are coming into your office? They have a heart issue. What are you now considering when it comes to their brain health?
Well, in one sense, it's not really going to change much because this information has already been known. I think what it's going to change is it's going to remind people and sort of prompt people to go a little bit outside of what their prescribed specialty is, because as Marianne was saying, there is a bit of an issue of saying, well, I'm only going to fix this sort of stuff that's in my very narrow wheelhouse. And I think there's a growing realization, especially as people don't have family doctors in this country, especially as it's becoming harder and harder to access different specialties, we are going to all have to become a little bit more generalized in our practice. And so realizing that, yes, you can treat the cardiology aspect of it, but you should be screening for depression, screening for dementia, treating all the other things that go along with it, because all of this stuff is very largely interconnected.
Dr. Labos, is this something you've seen in your practice before? If a patient has something like atrial fibrillation, for instance, where you look not only at that, but also the potential impact on their brain, whether they're experiencing any cognitive decline or anything that may indicate that may be coming?
Oh yeah, no, this is very, very common. I mean, and part of the problem is sometimes we don't often talk about it enough, but after a heart attack, very common for patients to have depression, usually short-lived, usually it gets better, but it is a very, very common phenomenon, atrial fibrillation, because of the micro strokes that can happen with it. It does predispose patients to a specific type of dementia called vascular dementia. And so we do as much as we can to try to prevent it by giving them blood thinners when they have atrial fibrillation and trying to treat the heart disease as best we can. But there are going to be a subset of patients that need to be prescribed antidepressants. There are going to be patients that need to be screened for dementia and then either referred or managed in some way. And I think what what is potentially problematic is that if you're just focused on the one thing, you will let everything else go, assuming somebody else will pick up the slack. But we are increasingly in a situation where there is nobody else to pick up the slack. It is going to be on you to take care of it.
Yeah, and that is the reality. Just trying to find a specialist, I think with your patients, trying to get to a cardiologist may have taken them months, if not longer. Although Marianne's using terms like atrial fibrillation. Maybe you're a cardiologist on the side or something like that. I don't know.
I'm learning lots this morning.
I'm
Dr.
sure you
Labos.
are. Chris Labos, you're going to get a run for your money. I want to talk about cholesterol levels and also blood pressure levels, because there's this interesting discussion around when somebody has low blood pressure, what that might be the harbinger of when it comes to brain health.
Okay, so get ready, because this is going to be a 45-minute discussion about blood pressure. So
all right,
clear the schedule for the rest of the morning. So listen, blood pressure, probably one of the most important cardiovascular risk factors that we need to treat, because if it's too high, that's going to predispose people to stroke, and stroke then leads to vascular dementias, right? So obviously strokes are bad. When you have low blood pressure, though, that can be problematic as well. Usually it causes symptoms where people become lightheaded, they become faint, they become tired. So usually people feel it, especially younger people. And then in that circumstance, you just have to ease off the medication to let their blood pressure normalize. But in older patients, this is a particular concern, because there is a worry that low blood pressure, because you then hypoperfuse the brain, meaning you're not getting enough blood and oxygen pumped to the brain, that you might be contributing to symptoms of dementia, of neurocognitive decline. And so managing blood pressure in older patients can get a little bit tricky, because you don't want it to be too high, but you don't want it to be too low either. And I think this practice guideline is shining particular focus on that, and to realize that this is something that it's not just, prescribe medication and then walk away. Make sure the patients are checking their blood pressure at home. Thankfully, most people nowadays have a blood pressure monitor at home, so they can keep track of it. And there's other things you can do, like have a 24-hour monitor when patients can't check it at home. So there's a lot that you can do, but you do have to make sure that you're managing blood pressure carefully, and realizing that, especially in older patients, some very atypical symptoms might be a sign of their blood pressure being too low, and that being an indication that you need to ease off the medication.
You said it was going to be 45 minutes, but that actually made sense to me, and it was a lot less time than that. You have another one.
I was just curious, looking at these recommendations then, and the fact that they are more tailored, putting into perspective what the patient experiences, and also gender and sex, which we talked about just a few moments ago. Why is that important in helping patients get more of that holistic treatment, which is so key here?
Well, I think the thing to remember is that everybody's different, right? We make guidelines because you do need to have guidelines, but guidelines are not rules. Guidelines are general recommendations of what you should be doing to treat patients. But you have to realize that there's a certain degree of variability there. So you have to tailor the approach to everybody. Just to harken back to blood pressure, it's not just a one-size-fits-all approach to prescribing this dose of this medication. You have to adjust it based on what the patient's blood pressure is. So you have to adjust based on blood pressure, adjust based on cholesterol, adjust based on a particular patient's side effect profile. And so that degree of adjustment is part of personalized care. That's why we have a doctor-patient relationship. That's why we have regular follow-ups, because if it was easy, we would just give people medications and walk away. But that's not how you sort of optimize cardiovascular health and optimize people's risk factors.